Hi, good afternoon. It's Sunday afternoon and this is my third Instagram Live for some of you who have seen the others before. Today I thought I would talk about HRT, the three-letter word that causes so much confusion, so much worry, so much that people don't know about. So I really want to just spend some time demystifying it for you all. Just to let you know, I'm a GP and menopause specialist. I am not paid by any pharmaceutical company. I don't have any hidden agenda. All I want to do is give people evidence-based, non-biased information so they can make the right choices for them about their menopause. So for those of you who haven't caught up with my other two Instagram Lives, the first one is about the menopause, a general one, and the second one is aimed for women who are young, who've had an early menopause. So I'm not going to go into too much about the diagnosis and the symptoms because I really want to crack on with the treatment. But just as an overview, menopause means when periods stop, and officially it's a year since your last period. A lot of women are perimenopausal, so they're experiencing menopausal symptoms but still having periods that have changed in nature or frequency, and that can occur for several years before the actual menopause. Because the hormones estrogen and also testosterone are very important for most of us, we have cells that respond to these hormones all around our body. And these hormones, when the levels reduce, can cause symptoms such as hot flushes, night sweats, which are the common symptoms that everyone thinks about with the menopause. But actually other symptoms cripple women more, such as low mood, anxiety, fatigue, palpitations, poor sleep, joint pains, muscle aches, even hair loss and skin changes, vaginal dryness, reduced libido, urinary tract infections, bowel problems, dry eyes. The list goes on and on and on because these receptors to our hormones go everywhere. So why do women take HRT and what is it? So HRT just means three letters: hormone replacement therapy. And what I really want you to think about with the menopause is not thinking about the menopause equals symptoms, because symptoms can sometimes improve with time or they can change with time. The menopause is a female hormone deficiency. So it means that once a woman has gone through her menopause, either naturally or surgically or due to drugs, and the ovaries aren't working, there's no hormones being produced or very little hormones being produced, there is a deficiency in hormones, which means that the body can't get estrogen and testosterone. It can get a small amount of estrogen from some fat cells, and that's why women tend to put on weight during the perimenopause and menopause, but actually you can't get enough. So we have to think about it as a long-term hormone deficiency. And why is this important? Well, actually, it's important because we're living longer. In the Victorian times, we used to die a couple of years after our menopause, and so women wouldn't have long-term health problems with having low hormone levels. You could, if you look back in history, a lot of women actually were locked up in asylums, and this was in the Victorian times, and I'm sure this was related to their menopause and the psychological impact. But they didn't have long-term health risks and health consequences of these low hormones. If you think now, the average age of the menopause is 51. For some women, it's younger. And our average life expectancy is, well, the average death of women in the UK is around 82, 83. So potentially we're living 30 years without our hormones. Now, hormones are very important in the lining of our blood vessels, in our cardiovascular system. In our bones, they're very important. In our brains, the hormones are very important. So if you take a step back and think about how your body is responding without hormones, you'll realise that without these hormones, there's an increased risk of diseases the longer we live. And these diseases include diseases such as heart disease, osteoporosis, type 2 diabetes, depression, dementia, even osteoarthritis, because the hormones are so important and we have so long without them. So when you think about hormone replacement therapy, you have to think about it as replacing a deficiency. And once people think like that, then it just makes it a lot easier to think about why you're taking HRT. So if you, for example, had an underactive thyroid gland, you would see your doctor or nurse or healthcare provider, and they would give you thyroxine, which is a type of hormone replacement. You're replacing that missing hormone thyroxine, and you will take it forever because your thyroid will, for whatever reason, not work again. If you had type 1 diabetes, where you weren't producing insulin, another hormone from your pancreas, then you would take insulin, usually as an injection, for the rest of your life, and the dose will vary depending on your sugar levels, and some people who have diabetes find that their requirement for insulin is low initially and then it gradually increases or changes depending on what they do, whether they have any infections, whether they're doing exercise, all sorts of things. But people with type 1 diabetes will take insulin forever. They won't stop it after a certain length of time or at a certain age, and you'll see why I'm talking about this in a bit. So we need to think, as doctors, as healthcare professionals, we when we learn about the menopause, we learn about symptoms but also diseases associated with the menopause. And for many of you who know about my work, I'm a GP, but I've done a lot of hospital medicine. So I'm very interested in disease prevention. And the most important disease in women and also in men is cardiovascular disease. That causes more death worldwide than any other disease. And also diseases such as osteoporosis. It's quite a hidden disease. It's not talked about very much in the media, but it causes a lot of morbidity and also mortality in older women. And we also know about dementia. 1 in 2 women over the age of 80 are thought to have dementia. And dementia is far more common in women, and it's thought this is related to the low hormone levels that occur. So we need to think about why we're taking HRT, and then it makes it easier to understand the benefits and the reasons to take it. So what hormones are there in HRT? Well, the most important hormone is estrogen, and estrogen is the hormone produced by our ovaries, and when levels start to reduce during the perimenopause, they often don't reduce like that. They often reduce sort of a bit wavy. So some people find that they have very high levels one day and then very low levels and then high, and this is often why people get mood swings and variation in their symptoms. But actually with time the estrogen levels drop, and after the menopause these levels are very low and they stay low. And estrogen, like I've already said, is important all over the body. So estrogen is really the most important hormone for HRT, and all types of HRT should contain some type of estrogen. So if you see a doctor who isn't giving you estrogen, you need to question why. Now some of you who are listening might think, oh, but I've got estrogen dominance and I don't need estrogen. Well, there is very little research about estrogen dominance because people don't stay dominant forever. It's usually they have this fluctuation, and usually actually by giving estrogen stops the internal fluctuation. There are some women who have sent questions, and thank you, I've had lots of questions, actually have said, well, I've been given the progesterone only pill, or I've been given the Mirena coil, and I'm perimenopausal, and my doctor said, let's try this first. Well, actually that's not HRT, and that's not going to help the bones, heart, brain, everything else that needs estrogen. So you should be pushing back and saying, well, why are you only giving me progesterone? That doesn't make sense. So estrogen is really important, and this is the building block, if you like, for HRT. Now, in the past, estrogen used to be derived from pregnant horses' urine. Really quite grim, I know, but that was a way of them getting the estrogen, and it would come as a tablet. Nowadays, estrogen that we prescribe is usually as a patch or gel, and actually there's a spray, which I'll talk about later, that's come out as well, which go through the skin. And this is a natural body identical. Body identical just means it's the same structure as the hormones we produce ourselves. So the estrogen is actually now derived from the yam, the root vegetable. So no horse's urine, it's natural. And lots of people want natural products, but they don't realise that what we can prescribe is still very natural. So that's the estrogen. And then if a woman still has their womb, so hasn't had a hysterectomy in the past, they also need to take a type of progesterone. Now, progesterone is also produced by our ovaries, and we know from research in the past that estrogen on its own can lead to some thickening of the lining of the womb, some changes in the lining of the womb, and for a very small percentage of women there can be an increased risk of cancer of the lining of the womb. So certainly as doctors we don't want to cause any problems with women, and certainly not cause any cancer. So what we do is we give a progesterone as well, with the estrogen, and then that protects the lining of the womb. So with progesterone there are different types. When they're synthetic progesterone, so therefore they're not the same structure as we produce ourselves, they're not body identical, then they're called progestogens. And this is where it can be complicated, because you can read about progesterone, progestogen, and you think, oh, what is it? So progestogen just means synthetic, so man-made. So it's like progesterone but slightly different. Whereas the progesterone is the hormone we produce ourselves that women need if they still have the lining of their womb. And then the other hormone that some women benefit from, a lot of women struggle to get, and I'll talk about in a bit, is testosterone. And that's weird, isn't it? Because we all know that testosterone is produced in large quantities in men. So why do women have it? Well, interestingly, our ovaries produce more testosterone than estrogen before the menopause, so higher quantities, and it gradually declines as we get older. Some people debate whether it declines because of the menopause or just because we're getting older. But actually we have testosterone receptors in cells all over our bodies, especially in our brains, in our heart, even in our vaginas. And so a lot of people benefit, a lot of women benefit from having testosterone replacement as well, because it's another important hormone. So before I go into how to take it, I want to just take a step back and for you to understand why there's so much controversy about HRT. So when I graduated, so I'm quite old, I graduated in 1994, and around that time we used to give HRT out by the bucket loads. Anyone with any symptoms, we would just give HRT, and this was actually the horse's urine type of HRT, because an older type of progestogen, because that was all that was available. But I would give it to women, they'd feel better, it was great. And so most people did. It was a bit like if someone came and they had hypothyroidism, like I said before, underactive thyroid, give them thyroxine. Menopausal woman, give them HRT. And then, because people worldwide were realising there were big benefits, because women were feeling better, but also their longer term health seemed to be better. They had less risk of heart disease, less risk of osteoporosis, less risk of dementia. So they decided to do a big study. Now, a lot of you might have heard of this study. It was called the WHI study, the Women's Health Initiative study. Bit of a mouthful. It was a multi-million-pound dollar study. It was in America. And the study has been flawed for lots of reasons, and I haven't got long enough to go into all the details. But suffice to say, what they were doing was looking to see if older women benefited from taking HRT. So they knew perimenopausal and women who were recently menopausal benefited. So what they did was they recruited women from all ages, but a lot of the women, the average age in the study was 63, which is, as you know, about 12 years older than the natural menopause. So a lot of these women had gone through the worst of their symptoms. A lot of them weren't even experiencing symptoms of the menopause. Also, a lot of these women were overweight and obese, and also a lot of them had had heart disease before. So they were at risk of heart disease because of their history, but also because they were obese as well. And this study was looking at giving them placebo, so a smartie if you like, compared to giving them HRT. And the HRT they gave in this study was the tablet estrogen derived from the pregnant horse's urine, and a synthetic progestogen called medroxyprogesterone acetate, which is an old type progestogen, and it would be combined as a pill. There were some women who'd had hysterectomy in the study and they didn't have the progestogen because they don't need it, they just needed the estrogen. They gave them quite a high dose. They gave them a higher dose than we would normally give to women who are in their 60s, and they followed these women up. And what they found with time was that some of these women were experiencing heart attacks, and there was a small increased incidence of breast cancer. So the study was stopped very abruptly, and unfortunately it was stopped in the summertime, and it was leaked to the press before any good researcher got their hands on it to analyse the study properly. Because it was in the summer, a lot of experts, specialists were on holiday, they couldn't get hold of them, so the journalists just interpreted what they thought. And so it was a massive nail in the coffin for HRT, because people would read in the headlines, HRT causes breast cancer, causes heart disease, and quite rightly, you wouldn't want to take something that caused breast cancer or caused heart disease. So people stopped taking it. And then they looked at the study properly, because as I've already said, it was a massive, big study. So there were lots of people involved, lots of confounding variables, lots of really important data to tease out. So they looked at it properly, and really interesting things came out of this study. Firstly, there were younger women in the study as well. I said the average age was 63, so there were younger women. And they found from this study that women who took HRT, either the tablet estrogen on its own or the combination estrogen and progesterone, when they took and started the HRT when they were within 10 years of their menopause, so for most women that's under the age of 60, they had a far lower risk of heart disease. They had a lower risk of dementia. They had a lower risk of osteoporosis. And the women who only had estrogen, who had a surgical menopause, so they've had a hysterectomy in the past, actually had a lower risk of breast cancer. And I'm going to talk about surgical menopause in a couple of weeks. So the women who were beyond 10 years of their menopause, so these are women in their 60s, 70s starting HRT, those women were found to have a small increased risk of a heart attack, but more in the people that took the combination estrogen and progesterone. And there was a small increased risk of breast cancer in these women who took HRT, the combined HRT, so the estrogen and the synthetic progesterone. But when they looked at the actual numbers, the numbers were very small, and the benefits seemed to outweigh the risks. So certainly the benefits for lowering the risk of heart disease, dementia, osteoporosis in these younger women really outweighed the risks. But the problem is, once the data was analysed and then tried to get media attention, it was too late, because everyone hated HRT. Since this time, so that was 2002, since this time, this study has been analysed, reanalysed. I've been to so many conferences where leading authorities have been tearing the data apart, and they've all come up with the same conclusion, that actually the benefits of HRT outweigh the risk, but the type of HRT is really important. And this is what I want to spend a bit of time just discussing with you. So when women take a synthetic progesterone, so like medroxyprogesterone acetate, norethistron, these progesterones are not the same as the progesterone we produce ourselves. They're synthetic, so they have risks associated with them, which was shown in the WHI study and has been shown in other studies. So these synthetic progesterones, when given with estrogen, have a very small, and all these risks are small, but there still is a risk, a small increased risk of clot, a small increased risk of heart disease, a small increased risk of raising cholesterol levels, and a small increased risk of breast cancer. So that leads us to think, well, actually, if you had an alternative, wouldn't it be better? And we do have an alternative. We have something called micronized progesterone. Now, the progesterone bit, I've already said, is just the same as our bodies produce ourselves. The micronized bit just means that what they do with the progesterone, if you try and take progesterone normally as a tablet, it doesn't get absorbed into the body. And this is why it's taken a long time for somebody to come up with it. So they micronize it. So what they do is they make the particle sizes very small. So they're less than 10 micrometers across. So very, very tiny. And this increases the surface area of the drug. And that means that it's more able to dissolve, but also more able to be absorbed into our bodies. It's suspended in some oil and also some gelatin as well, and it's an oral capsule. So in the UK, ours is called Utrogestan. I know this is back to front, but it's these tiny little capsules, hard to see, but they're sort of gel-filled capsules that can be taken orally. And this is the natural progesterone. Micronized Progesterone, and in the USA it's called Prometrium, and like I say, in the UK we call it Utrogestan. There's only one type, and the studies have shown that the natural progesterone doesn't have an increased risk of clot, it doesn't have an increased risk of heart disease, and interestingly, for the first 5 years of taking it, it doesn't have an increased risk of breast cancer. After 5 years, it's thought there might be a small increased risk, but the risk is smaller than with the other older types of HRT. But I've already said the risk is small. So how do you quantify risk? If someone says to me, Louise, you've got a 2 in 1,000 risk or a 20 in 1,000 risk of developing, or say for example, of having a car crash, pre-COVID, I would have needed to drive and pick up my children from school, so I would take any risk to get my children. But actually, when someone talks about numbers, it's very hard to quantify, because I'm not thinking about all the other 999 people when it's talked of over 1,000. I just want to know about me. So I find it easier to compare the risk. So for example, a woman who takes an older type of HRT has a combination HRT, so estrogen and synthetic progesterone, has a small increased risk of breast cancer, which I've already said. But actually there are other risk factors for breast cancer, such as not exercising, drinking alcohol, being overweight, not sleeping well even, is a risk factor for breast cancer. So a woman who takes a synthetic type of tablet combination HRT, her risk of breast cancer is about 10 times less than a woman's risk who doesn't take HRT, who's obese, or far less than a risk of a woman who's drinking a couple of glasses of wine a night. Whereas a lot of women will drink a couple of glasses of wine a night and not worry about a breast cancer risk. Whereas taking HRT, they'll say, no, I don't want it because there's an increased risk of breast cancer. And increasingly we see women in our clinic who come and they're drinking more alcohol because they want to numb the symptoms of the menopause. They're exercising less because they've got joint pain, muscle stiffness, they're fatigued, and they've put on weight. So they're increasing their risk of breast cancer, but they sit there and say, no, my doctor won't give me HRT because of the breast cancer risk. We give them HRT, often the natural progesterone, so the lower risk of HRT form. When we see them back in their clinic, they tell us that they're drinking less alcohol, they're exercising because they feel better, they're eating better, they're losing weight. And so actually their overall risk of breast cancer is reducing, even if HRT increases a little bit. So you've got to think of it as a dynamic process. It's not just HRT, breast cancer. There are other reasons why women get breast cancer, and we need to look at lifestyle factors as well. The other thing is that taking HRT reduces risk of all those diseases I've mentioned, such as heart disease, type 1 diabetes, dementia, osteoporosis, and the commonest cause of death is cardiovascular disease. So taking HRT reduces the risk of these conditions, and this is why it's important to look at why you're taking HRT. Now, there are some women who can't take HRT, and these are usually women who've had an estrogen receptor positive breast cancer, and I'm going to talk about menopause in women who've had cancer next week, so I don't want you to think that I'm excluding those women. But most women can actually take HRT. The studies have all shown that the best time to start taking HRT is actually when you're perimenopausal, so your hormones have started to reduce, or certainly within 10 years of the menopause. So for most women that's under the age of 60, starting HRT. But there are still women who can take HRT safely who are older, and certainly some questions have said, well, when can have I left it too late? I've been found out that I've got osteoporosis, I'm 63, my menopause was when I was 48, can I still take HRT? And a lot of women still can. We often start with a low dose and then gradually increase. So there are still benefits to be had, and we know from studies that even a low dose of estrogen can actually help strengthen bones, for example. So there are health benefits of being on HRT. So there are other people that are incorrectly told that they can't take HRT, and so many times on my Instagram account I see people that have had a history of a clot in the past. So a clot, either a clot in their legs, or an embolus, a pulmonary embolus, a clot in their lungs, or sometimes a family history of clot, and they've been told they can't have HRT. Now, the reason doctors sometimes are educated about this is because you can't take tablet estrogen if you have a risk of clot. I've already said there's a risk of clot with the synthetic progesterone, so you wouldn't want to take that if you've got an increased risk of clot. But also taking tablet estrogen increases your risk of a clot, because when you have it orally, it activates your liver, which produces clotting factors. So there's this double risk. Double sounds scary, sounds a lot, but actually most of us, our risk of clot is very low. So doubling a low risk is still low, but if there's an alternative, you might as well go for the alternative. So having it as a patch, gel or spray means there's no increased risk of clot. So women who have risk factors for clot can still take HRT. So if they've had a family history of clot, like I've said, but also if they're overweight or obese. Obesity is a contraindication, i.e. you shouldn't take tablet estrogen, but you can take the estrogen through the skin. A lot of people are told that they can't have it HRT if they've got high blood pressure. Actually, the guidelines we work out of, the NICE guidelines, the National Institute of Health and Care Excellence guidelines, are very clear that even if a woman has cardiovascular disease risk factors such as raised blood pressure, they can still take HRT, but as doctors we need to manage their blood pressure. Interestingly, there's some studies that show that the estrogen through the skin as the patch or gel or spray with the micronized progesterone can lower blood pressure, and it can certainly lower cholesterol as well. So very interesting. And actually taking HRT reduces your risk of heart disease more than taking a blood pressure tablet. I have a lot of patients who have a history of blood pressure, and often we carry on with their blood pressure treatment or start blood pressure treatment if their blood pressure is raised, but they can still safely have HRT. So that's just reassuring. Some people have asked about if they have raised cholesterol. Well, yes, of course, you can still take HRT. Having the natural body-identical hormones, you can still have it if you've got raised cholesterol, and a lot of people find their cholesterol reduces with taking HRT. Some people have asked about thyroid disease, and when we're in our mid-40s, 50s, we have an increased risk of thyroid disorders, and a lot of people find that their thyroid hormone blood tests are more abnormal around the time of the perimenopause and menopause, but a lot of people find they normalise with taking HRT because all these hormones have a sort of cycles, they're all interconnected. If you have very abnormal thyroid function tests, then certainly you should take thyroxine if it's underactive, but you can still take HRT as well, so you don't need to delay taking HRT. And then what about those women who have a family history of cancers, for example, a family history of ovarian cancer or breast cancer? Yes, they can still take HRT. Taking HRT doesn't increase the risk of ovarian cancer, and women who have a family history of ovarian cancer, so cancer of the ovaries, can still take HRT. Women who have a strong family history of breast cancer can still take HRT, and in fact some studies have shown those women have a lower risk of breast cancer, so it's not a reason to be refused it. Sadly, a lot of women are still offered antidepressants instead of HRT, but there's no evidence that they'll help the low mood associated with the perimenopause or menopause. So if you feel that you should be offered HRT and you're not, you need to start talking about the NICE guidelines and really question why your doctor's doing this. So I've already said when to start it, sooner the better. You don't need to wait till your symptoms are really bad, until you've given up your job or your partner or your career or thinking about ending your life, which is what a lot of women who come and see me in my clinic are, because they've had symptoms for so long. The sooner you start HRT, the sooner your symptoms will improve, and the sooner you'll feel better, but also the better for your bones, your heart, your brain, your health. So you don't have to wait. And then how long do you take it for? Well, if you were listening at the beginning when I was talking about the menopause being a long-term female hormone deficiency, then you take it as long as you've got that deficiency, i.e. you take it forever. So you don't need to stop taking it. In the past, people used to say you stop taking it when you're 60, or if you've been on it for 10 years, and that doesn't make sense because you want to replace the hormones. Some of this is because of the risks associated with the older types of progestogens, and the tablet estrogen, because our risk of clot is increased as we get older, certainly above 60. But because we can have it through the skin, because we can have the natural progesterone, then we can take it forever. So the day you die is the day you stop taking HRT, because the benefits outweigh the risks of HRT for the majority of women. So I hope that's helped give you a bit of a background as to what HRT is and how safe it is. There are some other types of HRT. There's a tablet called Libial, or Tibolone is the other name, that a lot of gynecologists use, which is very synthetic. It's a combination HRT. We tend not to use it in our menopause clinic because we like the control of having the estrogen, progesterone, testosterone separately. Some women who have endometriosis, which I'm going to talk about in a couple of weeks' time, are given something called Zoladex, which suppresses all their hormones, and then have what's called add-back HRT. And so Zoladex isn't a type of HRT, it's a treatment to suppress hormones. So how do we take it? How do I know when someone comes to see me in my clinic, or now virtually sees me in my clinic because we're doing video consultations? How do I know what to start? What dose? Is there a blood test? Is there a magic test that I can do? Well, there isn't. And we tend to diagnose the perimenopause and menopause based on symptoms. And you've seen this questionnaire before, if you've logged on before. If you search questionnaire on my Menopause Doctor website, you'll see a list of symptoms, commonest symptoms, and they're graded depending on how severe they are. So we ask women to fill this out, and then we just ask them a simple question. We ask them about their periods. Are they still having periods? If not, when did they stop? Have they changed in nature or frequency? And if they have stopped or changed and they have symptoms, then I don't have to be a brain surgeon to work out that they're perimenopausal or menopausal. We don't need a blood test to diagnose it. And so if a woman has had a hysterectomy or has a Mirena coil in, so is not having periods, she's had a hysterectomy, then when she's had a hysterectomy, she only needs estrogen and possibly testosterone. She doesn't need a progestogen. There are a few women who decide to take progestogen for other reasons, but actually the majority just need estrogen. And so they have estrogen through the skin as a patch, the gel or the spray. And this is a personal choice. What we do in the clinic is show people. So I can show you now what they're like. So the estrogen, who many of you have seen before, it's called Estrogel, or there's Sandrina, which is this little sachet. These are the ones that are available in the UK. And the gel, I've shown you before, but I'll show you again, is just, you can see here, I wouldn't make a very good photographer, is this clear gel that gets rubbed in on the outside of the arms or the inside of the thighs. And the dose changes. So the dose, we usually recommend around 2 pumps a day, but it can increase. And most women need between 2 and 4 pumps a day. But as I said last week, younger women often need higher doses. A lot of women find that it really starts working quickly, and then when they come back to the clinic or get reviewed in about 3 months' time, they say, do you know what, I felt great for 2 months and then I felt awful. All my symptoms came back. It's not working for me. And that's often because they need a higher dose. And with the gel, people can be flexible. A lot of women have asked me whether they can increase the dose themselves. And actually, yes, you can, because the dose is very small. Each pump is a very small dose, and it only lasts in the body for the day that you use it. That's why it has to be used every day. So what I put in my body today is pretty much gone by the next day. So you're not going to get a build-up in your system or anything like that. So if you feel, certainly now in COVID, when it's very hard to get hold of your own doctor, and I know a lot of menopause clinics have closed at the moment, and you're still getting symptoms, you can increase. The commonest side effects if you have too much estrogen is you can get some breast tenderness or some bleeding if you've still got your womb. And then you can just go back. So if you feel that you get side effects, the next day just use less, and then you'll be back to where you were before. So that's the gel. And then the patches, which I know I've shown you before. This is one of the patches. It's just a very thin plaster really that goes usually on the lower back, around the buttock area or on the thighs. And the patches we tend to recommend last twice a week you change them. So usually I change mine on a Monday and a Thursday. This is just another type of patch to show you. You can see it's smaller, it's about the size of a postage stamp, slightly thicker, but again it's very easy. There are different manufacturers, and it really depends on your skin type as to how they stick. The shortage of patches is still a real problem in the UK, but we're seeing a trickle through of the Everall patches, so we're hoping that will improve with time. And then this is the spray that was just sent today, actually. So this is a placebo, and it's called Lenzetto, and it's just come out in the UK. I saw it at a conference a while ago, and I'm going to show you it actually. And I thought, wow, this is really good, and I've been waiting for about 3 years. I have a sad life. I was very excited when this came. So you'll see it comes, and it's a spray, and it's got this sort of nozzle here. And what you do, I'll show you. You put it on your arm, and you literally just spray. Oh, I can do it. Let me do it again. So you spray like that, and then you might be able to see, I don't know, my skin's a little bit wet here. And then if I need another one, if I have a higher dose, then I just move it slightly along and give another spray. And you'll see my skin's slightly wet, and it recommends you just leave it to the air for a minute and it gets absorbed. And certainly this is the placebo. I haven't tried the real thing yet. It does get absorbed very easily. And the dose of a spray of this is actually slightly higher than a pump of this. So there are certainly some young women who find they're using 6-8 pumps of gel and they run out of skin quite quickly. So this is going to be a good alternative. It can be used on the forearm here or on the thigh if you run out of skin. So I think this is something we'll be using more in our clinic. And it's really good to have a choice. And some people use patches and top up with gel if they are experiencing symptoms. So the estrogen is used every day or changed twice a week if it's a patch. So that's the estrogen bit. And then the progesterone, like I say, we normally use the Utrogestan, this Micronized Progesterone, or a Mirena coil. So Mirena coil is a synthetic progestogen, but it's a very, very low dose because it just works locally in the lining of the womb. So it's thought that it doesn't have this risk of breast cancer or risk of clot or risk of heart disease, so it's very safe and it's a good contraceptive. It can be used for 5 years as part of HRT. So if a woman wants contraception and is having heavy periods that are troublesome, we usually recommend a Mirena. Or, like I say, the Utrogestan. Now, there are 2 different ways of prescribing the Utrogestan, and it always causes confusion, so I try and keep it simple. So if a woman is still having her periods, or her periods have only stopped around 6 months ago, we recommend you have it in a cyclical or sequential fashion. So it means that you'll still have your periods. What we recommend is that you take 2 of the capsules orally, so by mouth, at night, because they can cause a bit of sedation. So they can help people sleep, so that's quite a nice side effect. On an empty stomach, because if you have a full stomach, the absorption increases a little bit, which isn't the end of the world. So you take 2 at night for 2 out of 4 weeks. It's actually licensed for these just 11 days of the month, but we don't want to be counting days too much, so it's easier to do 2 weeks on, 2 weeks off. And so women have 2 weeks where they're just using the estrogen gel. The next 2 weeks they carry on with the estrogen gel or patch or spray, and then they take the Utrogestan at the same time. A lot of women find it makes their periods more regular, easier to manage, and slightly lighter as well, so that can be beneficial. If a woman has been a year without her period, or even sometimes, more than 6 months after her periods have stopped, then we change and we recommend they have it as a continuous way. So it's 1 capsule at night all the time. So it's licensed for 25 days, but out of 28, but we just recommend all the time because then it's easy, you don't need to worry. And that way your periods won't come back. It's a period-free way because most of us don't want periods and they're a right pain. So anything you can do to stop is great. Once a woman, if they've had the sequential type, where you're 2 weeks on, 2 weeks off, for about 6 months to a year, after if everything's going well, then we change those women so they have period-free HRT. So even women who are young, for example, in their 30s, have started HRT, been on it for a year, having periods, and then we change it so they have period-free. And it's better for the lining of the womb because it's not stimulated, so there's no risk of cancer of the lining of the womb, which is obviously very good. So That all sounds great, doesn't it? All wonderful, wonderful. But actually some women say, oh, I don't like the progesterone. It makes me feel tired, makes me feel moody, it makes me feel irritable, can cause some spots. And the older types, the synthetic progestogens, are more likely to cause those side effects. So if someone has, for example, is taking a combination tablet or a type of older progestogens such as the medroxyprogesterone acetate or norethisterone, then the first thing we would do is change them onto the body identical hormones. Then if they're still getting side effects, which some women do with the Utrogestan, then you can take the Utrogestan, you can use the same capsules vaginally. So all you do is insert the this capsule vaginally, and if you shove it up, it's not going to get lost or go in the wrong place, and it works locally to protect the lining of the womb, which is where it's needed, but less gets absorbed into the body, which is good, so there's less side effects. It can be used at half the dose, so if someone's taking it for 2 out of 4 weeks, they only need to insert 1 for 2 out of 4 weeks, or if they're taking the HRT continually, so 1 at night, then they can just take this every other evening, internally, vaginally. This is off license, so it's not licensed that way, but we've got good evidence to show that it can help. For those people that find they don't like this, or it irritates the vagina, or they don't want to take gelatin, then there is a pessary called Cyclogest in the UK, which has just got progesterone in it. And it can be cut in half. The 200 milligram can be cut in half and used the same way as this. So there's always alternatives. There are still some women who still can't tolerate it vaginally, and those women would need to come to a specialist clinic, because there are other ways to work around sometimes, but you really need an individualised consultation. Now, just to warn you, the inserts that are with these medications, the estrogen, progestogen and micronized progesterone, are really outdated and they're wrong. So you might have listened to me and think, this is great, I'm going to go on this stuff. And then you pick this up and it will say, oh, risk of clot, risk of stroke, risk of breast cancer, risk of death. And you'll say, well, that Dr. Newson was talking rubbish, because this is all here and this has got to be right. Actually, this is wrong, and this has come out because they've grouped all the hormones together, and there's a group of us who are liaising with the MHRA, the health, the regulatory authority for medicines, to get this changed. So this is absolutely wrong. This is based on the old types of HRT that were in the WHI study. So don't get alarmed by that. Now, the other hormone, testosterone, there are different types of testosterone that are available, and sadly we haven't got a licensed preparation for women in the UK, which is absolutely outrageous that we are denied our own hormone, and I'm hoping this will change. We can prescribe the male testosterone in smaller doses, but it's quite hard to titrate. So certainly in my clinic we usually recommend that women use this, which is called Androfem, which is a testosterone cream made in Western Australia, and it comes with a syringe so you can measure the amount. Most people guess it after a few days of measuring it, and it's a pea size. You'll see it's just a white cream that gets rubbed onto the thigh every day, and it's really important, if you have testosterone, to have your blood tests monitored to make sure that you're still in the female dose and female range, and then the risk of side effects is incredibly low. So we don't see bearded women coming to our clinic, but it can really make a difference to mood, energy, concentration. There is some evidence it reduces risk of heart disease and also dementia, so it's an important hormone. A lot of women really struggle to get it because their GPs haven't had any education about it, and if you do, you can be asked to be referred to a specialist clinic. Sadly, there's not many specialist clinics in the UK and the NHS. There are private clinics, and a lot of private clinics like mine, we do prescribe it, and we only need to see women once a year to monitor them and to review them every year if they need to be seen, to reduce costs. So these are all body identical, they're regulated. So even this that I've said isn't licensed is regulated. It's made in a factory, strict conditions. We know exactly what's in it. So when I prescribe these for patients, I know what's in them. I'm very confident and reassured what's in them. So these are body identical hormones. Some people refer to them as regulated bioidentical hormones, and I just want to spend a few minutes talking about bioidentical hormones. So the regulated bioidentical hormones are these in the UK. This is what they look like, and they're the same as body identical, so they're the same structure as the hormones we produce ourselves. There are a lot of private clinics who do compounded bioidentical hormones, and what these are is that they're made for them by pharmacists. They're made sort of bespoke for women, and what they do is they say they'll do a saliva test or a blood test, and they'll match the hormones exactly to that woman, so it's very individualized. Often they're given in lozenges. The progesterone is often given as a cream, and they're frightfully expensive. Now, I've been doing a lot of research into these, and there is no evidence that they should be used or given. A lot of women are turning to them because they feel they're safer, and there's really good marketing associated with them. And quite rightly, women are fed up of not being able to get HRT from their own GPs. So they'll go to a private clinic that has very nice advertising and information, and actually women need to feel listened to. So if you go and someone's listening to you, my goodness, it's lovely. It's so lovely if someone understands what you're going through. But if they're offering bioidentical hormones that are compounded, do not give them your credit card details, because there's no evidence that they help. When they say they're matching your hormone blood tests or your saliva test, you don't want them matched because you're feeling rubbish. That's why you're going to them. You want to know what yours were 10 years ago, and we don't know, and hormone changes all the time. So you don't need expensive blood tests or saliva tests to know what hormones to start with. Because they're compounded, it means that every time you have a prescription, it might be different. There might be contaminants in them. They might not actually contain the hormones that they've been told that they do contain, and we don't know the doses in them. The other problem is that when they are given the progesterone as a cream, we know progesterone doesn't absorb well through the skin. Because it doesn't absorb well through the skin, it's not protecting the lining of the womb. So if you're given an estrogen cream or a lozenge with the progesterone cream, then there's a real risk that you're not protecting the lining of your womb. And we've certainly seen quite a few women who have been to these clinics in the past. They've come to my clinic and they've had a lot of bleeding. We had one lady recently who sadly had endometrial cancer of the lining of the womb. I can't prove it's related to those hormones, but there's a real concern. And so certainly all the national, international menopause societies have got together and said we can't endorse these products. So the compounded bioidentical hormones shouldn't be given, because we have all the body identical hormones that are safe, and they're cheap. These are really cheap in the NHS, and even privately they're cheap. So you shouldn't be spending a lot of money on your hormones. So it's really important that women know the difference. And there is a leaflet on my website called Body Identical Hormones, and it actually says, what are body identical hormones? Are they the same as bioidentical? And they're not the same as compounded bioidentical. It's really important. So it's a lot to take on. If you're not sure, go to the website and just put body into the search engine and of my website, and you'll come up with this information. So it's really important. So what about any side effects? I've mentioned how great HRT is, and I know when I started my HRT, my mother-in-law, who takes HRT, and my mother kept saying to me, "Oh, how are you feeling? You must be feeling great." And I was still feeling awful. Emptying the dishwasher was a real effort, and I was moody and irritable, and I thought, what's the point? You know, all these people say how great HRT is. It took me a while. It took about 6 months to get the right dose and the right type of HRT. Initially, I didn't absorb it very well from the patch, and then I found out that I needed testosterone and I needed a higher dose of estrogen. So it's very important not to give up if you don't feel amazing after the first few weeks of taking HRT. And also, there are other reasons why we might feel rubbish. We need to look at our exercise and diet and lifestyle as well. So if people get side effects, there are different types of HRT. So like I said, most people, if they get side effects to the synthetic progestogens, we can change. Oral estrogen is more likely to cause side effects as well, especially digestion side effects, headaches. Women who have migraine as well can't have oral estrogen and synthetic progesterone, so we change those women to the gel or oral patches as well. So breast tenderness can be quite common. That can be quite common initially, and it usually settles down. The progesterone can often cause breast tenderness, and for some women, changing from the tablet, the capsule progesterone to vaginal can be enough to reduce breast tenderness. Some women, we suggest that they take evening primrose oil as well, which can help making sure that your bra is supported and fits you properly as well. People worry about weight gain with HRT. Actually, there's some evidence that having the estrogen through the skin leads to some weight reduction. Testosterone can actually sometimes convert fat to muscle, so women are less likely to put on weight and actually usually lose weight, often because they feel better and start to exercise more. Bleeding is the commonest cause of why women get hacked off with HRT, and bleeding can be quite heavy initially and it usually settles. So if you have bleeding for the first 3 to 6 months of starting HRT, or for the first few weeks after changing or increasing the dose of HRT, don't be alarmed, because this will settle down usually. Sometimes women need to have a slightly higher dose of the Utrogestan, the progesterone, or change the progesterone, like I say, to maybe consider a Mirena coil. So there are ways of changing if people get bleeding. Someone asked about some skin pigmentation they were experiencing, and the estrogen can stimulate the melanocytes, which are the cells that turn our skin brown essentially. And so some people get some brown spots on their faces or on their arms, usually sun exposed areas, and it's usually areas of sun damage in the past. Some women get this when they're pregnant, but they can get it with HRT. And it's really important to wear a good sunblock. We should do anyway in the sun, but especially over those areas. It's hard to actually reduce it by changing the dose of HRT, but usually women find that they wear a different makeup and they feel so much better taking the HRT, they continue with it. A couple of people have asked about if they have fibroids or polyps, can they still take HRT? They've had bleeding, their doctors have said they need to stop it while they're having their fibroids or polyps investigated. Yes, they can still continue. If you look on my website, there is some information about fibroids, and you can still have HRT if you have fibroids. If they're troublesome, then you should see a doctor and consider having treatment for the fibroids, but you can still continue on HRT. And finally, I did mention briefly last week about local estrogen, which is not HRT, it's localized estrogen for vaginal dryness, and I think I'm going to do a podcast in 3 weeks' time just on vaginal dryness, but these is the estrogen pessary or ring or cream, which can be used in addition to HRT. So it's not the same as HRT, and it's very safe to have both. Women who are taking HRT, we often do blood tests in my clinic to monitor that they're absorbing the estrogen properly. So we can do estrogen blood tests, we can do testosterone blood tests as well. The other blood tests we sometimes do are things like a thyroid test or an iron level, a blood count if someone's having heavy periods. Some of the bioidentical clinics offer DHEA, which is a precursor to testosterone, and that's often, I've seen that slip into some of their regimes, but there's no evidence that it helps. It's very weak. So women are better having the pure estrogen and the pure testosterone. So if any of you are going to private clinics to receive compounded bioidentical HRT, you should be questioning whether you should. And we have seen some horrendous cases in my clinic of women who have been spending a lot of money and still experiencing symptoms, and when we've looked at what they've been taking, it's not been the right dose or amount or even type of HRT. And I know it's hard. A lot of people have asked me, how do you access care? What do you do? And do you know, it's so hard, and I'm speaking as a personal experience, because when I finally realised I was perimenopausal after having quite a few months of feeling absolutely dreadful, I couldn't get HRT from my GP because they're very anti-HRT for the wrong reasons. So I had to see someone privately for my HRT, which is absolutely disgusting, but it wasn't expensive, and now I am thankful my GP will give it to me on my repeat prescription. So the first thing, if you don't get HRT or your GP is pushing back and saying you need antidepressants, then I would try and see another GP, or sometimes practice nurses. A lot of nurses can prescribe and push back and say, why aren't you letting me have it? There is a template of a letter on my website, which some people have used, just to try and say to your GP, please can you read the nice guidance, I really want to try HRT, I know it's going to help. So just try and feel empowered and strong as a woman. There are some clinics that, like I say, the NHS clinics are hard. A lot of women, certainly who we see in our clinic, are self-refer, so they refer themselves to the clinic, and then we often see them, not often, and then we do a very detailed letter which goes copy to them and often to their GP if they give permission, and the GPs then feel more confident prescribing because we've given that initial prescription. I am developing with some colleagues a menopause education programme which is going to be rolled out soon, which will really help GPs and nurses and pharmacists actually improve their knowledge and education. But in the meantime, I think it's up to us as menopausal women to try and educate our doctors. And so a lot of you I know have bought my book and written beautiful reviews about it, but a lot of people have actually bought it for their doctors as well, which isn't a bad idea. Just to mention as well, the app, the Balance app that we're developing, has got some really good, it's amazing. I saw some prototype of it last week and I'm super excited about it, but there will be a community so people can learn from each other, and actually there's going to be little graphs so you can see how people are doing on the gel compared to the spray or the patch, and so I'm hoping that women can really try and learn from each other. I've learnt a lot about the menopause through my own journey and my friends' journeys as well. And so we need to just come together to learn more and more about how we cope with side effects, how we change our dose, how we feel in control, because certainly all of us doctors who work in my clinic, we want our patients to feel that they are in control of their bodies, because the menopause lasts for decades. We want to have decades of a really good positive life, and you know, it's so difficult at the moment to keep positive with COVID, with being in lockdown, trying to look after our families, our jobs, our careers, our futures, our relatives. It can be so hard, and don't get it wrong, I find it really difficult too. But if we balance our hormones, we're going to balance our lives a lot better. So please, I hope this has been useful. Give me some feedback. Tell me what else you'd like me to talk about. As you know, I can talk for England about the menopause, and nothing phases me. So I'm very happy to talk about anything. Send me some comments. Let me know what you want me to talk about, and if there's anything else, any other questions, I'll be delighted to help you. A lot of all the information is on my Menopause Doctor website. Lots of free videos, free resources that you can help print them off, take them to your doctors, or show them to your doctors, as you're not actually going to your doctors at the minute with COVID. But just feel supported, feel listened to, and just don't neglect yourself, because it's really important that we all look after ourselves as menopausal women. So take care. Next week I'm going to be talking about menopause and cancer. So keep well, stay safe, keep positive. Thanks very much.